All righty. Well, it is 10:20, so we'll go ahead and get started. First of all, welcome everybody. You found yourself in the Health and Human Services track. We're here to talk about the availability of beds for those in crisis. So hopefully you're in the right spot. And thanks for joining us. We have a really great panel today. I'm incredibly excited about that. Before we dive into the topic, I want to pay our respects to our sponsors that make this all possible, especially for everybody to be able to join it at no cost. So ITC Midwest is our presenting sponsor. Thank you to them. And our track sponsor for the Health and Human for the inclusive, for the diversity, equity, and inclusion, if I could get those words out correctly, track is Inclusive ICR. And we have a short video from them that we'd like to play now.
Hi friends, Angelica Veneta, co-chair of Inclusive ICR. We are a coalition of over 220 employers in Eastern Iowa, all working together to grow the diversity and inclusion of our workforce, to create a space where employees feel a sense of belonging, included, and valued. Inclusive ICR is a proud sponsor of the Diversity, Equity, and Inclusion track of the Iowa Ideas Conference. As you participate today, be sure to connect with other Inclusive ICR champions, as we'd love to share information with you about our upcoming coalition meetings, projects, and how our work is impacting positive social change in our region. Be sure to check out our website at inclusivicr.org for upcoming events and our e-newsletter. Thank you and have a great conference.
Thanks again to Inclusive ICR. So this is one of those unique sessions where it falls under the Health and Human Services track, as well as kind of the alongside of the DEI world when we talk about availability of beds. First of all, I'm Brian Bush. I'm with the Gazette. I do some work both with the Gazette and Foliant's the parent company of the Gazette. I'm also a licensed mental health counselor and do some work with young people and families in our local community here in Cedar Rapids. Can we just take a couple of minutes with Steve, Marissa, and Mark? Steve, why don't we start with you if you just want to introduce yourself here quick to the group. Oh, we have Steve muted. There we go.
Steve Johnson with Broadlawn Medical Center. I'm currently a government liaison for Broadlawn Hospital here in Des Moines, and I've been in the behavioral health field for now, I hate to admit it, somewhere around 30 years. So so anyway, I'm happy to be here, and we've got some, obviously some great topics to cover here today, and so glad to be here.
Thanks, Steve. Mark?
Thanks, Brian. I'm Mark Serter from Shelter House. I'm the Associate Executive Director of this organization, and we're located in Iowa City. We're a homeless and housing provider. Worked in this field for over 20 years, and hopefully bring a unique perspective to the session of availability of beds for those in crisis that is maybe different than the traditional healthcare model that we think of a lot when we talk about this. So thanks. I'm excited to be here.
Thanks, Mark. And Marissa?
Good morning. I'm Marissa Ianson, and I work with Iowa Departments of Health and Human Services as the state's director for behavioral health and disability services. I'm really, like Steve and Mark, I'm really excited to be here today and to see all of the folks on the call with us. I too spent my entire career here in Iowa working in the field, going clear back to when I was a 17-year-old kid and worked direct support in a facility in my hometown. So these crisis services are something that's been developing here in Iowa. We're really excited to be here today to talk about it a bit. So thanks, Brian.
Yeah, thank you. Thank you all three for being here. And I've told this panel before that I think the three of them bring a really, really unique expertise and unique backgrounds to this discussion. So thank you all. Marissa, if we can start with you, we'll just kind of launch it out with this. I think that anytime we talk about the availability of beds, sometimes it's just important to identify what that actually means. When we think about hospitals and psychiatric facilities, community centers, all these different resources out there, can you just talk a little bit about the current state of, quote unquote, beds and resources across Iowa?
Absolutely. And it's a great question, Brian. I do think that sometimes in conversation in our past, we've been a little bit hyper-focused on an idea that we need more beds, and folks maybe sometimes misidentifying what the actual needs are. Our current state here in Iowa is when we think about inpatient psychiatric beds, for instance, which is a space that folks often target, we have frequent and consistent availability of inpatient psychiatric beds for adults in Iowa, but a lot lower availability for kids. We see differences that are geographic, certain areas of the state that have consistent availability and certain areas that consistently don't have availability. And we see that there's a lack of specialty care. So there's been work happening in real time to start to develop some higher level specialization. We think that's going to relieve some pressure in the space. And then we start to think about the other things that contribute here as well, because the reality is when folks need care and they're in crisis, we want it to be a last option, that they have to go to an emergency room or a hospital. So we're really working hard to develop community-based crisis services. And that's everything from a short-term stay in a space where there's 24-hour staffing and folks that are there and available to help, to crisis services that are coming intermittently into people's homes over a short-term period of time in order to support them through what's going on in their life in real time and right now. Because the crisis service array is big, it's actually really hard to measure it by beds, because sometimes it's chairs and sometimes it's happening in the community and in somebody's home. Sometimes it's happening telephonically through the work that we can do through crisis counseling on phone lines. So what we're really trying to do is have some targeted conversations about what are the needs, and then really thinking about how do we best serve the need in the way that's going to best serve Iowans. So it's a big effort underway right now. We've seen it develop in recent times, though. I mean, when we think about crisis services in the state, for instance, and you roll that clock back 5 years or so, we were just getting started. 10 years ago, it didn't really even exist. And so if you think about that timeline and between nothing to what we have now, which is there is availability of crisis services in this state, we've made a heck of a lot of progress in a pretty short period of time.
I think, Brian, the part I threw in there is just to further that of those ideas is that, from much of my career, we really advised people, families, people with mental illnesses, case managers, others, to take people to the emergency room when they didn't feel safe. And so now, as Marissa says, we're trying to turn the page on that one. And so it does involve trying to move upstream and get involved earlier on some of these crisis situations. So I think we've made progress, and I think there's a lot more work to do. But I think that's going to be a changing culture.
Yeah, that's interesting, that development in terms of what has happened in a pretty short amount of time, really, in the grand scheme of things. Marissa mentioned earlier, young people and the availability of crisis beds for kids, it kind of folded in on top of just that overall picture. And I'm curious, when we think about, sometimes there's that misconception that kids are just simply small adults, right? Well, the reality is that we know that they really do have different needs. Are the beds and resources available? Are they more limited? Are we facing other challenges when it comes to youth in Iowa? What are your perspective on that?
Sure, I can kick off from what we can kind of see from here, but I know that what folks see from our provider spaces, where they're directly seeing people come in the door, is something that we always need to hear about. From here, we can see what we can see through data sources, for instance, and a handful of things that we can see about kids is we need more, right? That we need more services for youth, just in a general sense. The reason that we know that we need more is that we have youth overflowing into places that are not the right match for their needs. And so what we end up with is multiple spaces of system involved youth, for instance, kids that are involved in a child welfare system or kids that are judicially involved. And to Steve's point from earlier, a lot of times kids that are involved in those spaces, we probably missed some opportunities for upstream interventions before they got there. But what happens is once we get to a certain space, there are very limited places that are able to care for those youth, especially if they happen to be displaying some great big behavioral outbursts, for instance. And that means they sometimes end up in the wrong spaces. They're in shelter care when really what they need is a behavioral health clinical approach that's far more therapeutic. Or they're kind of landing into those tracks with the juvenile justice spaces when what they really need is care. We have a lot of work to do to develop those spaces. part of that is because we've consistently in our state siloed our work away from each other. The work that we did when we thought about child protective services, and the work that we did when we thought about what Medicaid pays, and the work that we did when we developed the services that are developed out of like my division of HHS, which is behavioral health or disability services. It was always kind of in its own space. We're working really hard to bring that work together here, so that we can kind of cascade that through to our providers and ultimately to Iowans, and do a better job of having a comprehensive approach to care. But it's going to take all of us to get there. You know, I can think about it all day long, but I need Steve and Mark and everybody else to help us get from here to there and figure out how to do it.
Yeah, and I think, you know, Mark, Brian, in Iowa, we've got some great child mental health providers, behavioral health providers. I mean, Orchard Place, and there's more here in the central area, but they're, you know, they've been around since orphanages were developed around the last turn of the century, and they've got a great clinical staff. They operate a residential services as well as other services. So, and that's just one example. There's a lot of great child mental health providers, and the child mental health is a distinct workforce. Many of the psychiatrists, therapists, other mental health professionals that go into this type of work are focused predominantly on adult mental health care, and there's certainly a large need there. But you touched on it before, Brian, in terms of, yeah, they're not just little adults, they're complicated, and there's complications. There's, as Marissa indicated, there may be abuse or neglect issues. You know, there may be, you know, juvenile court issues. So they're more complicated, and it's more as a therapist or a psychiatrist approaches that work, it's much more complicated and can get harder. So I think the good news is we've got great child mental health providers. We've got hospitals that provide, you know, inpatient child mental health care and other care. The caveat I'd put on things right now is we do have some beds out of commission related to the workforce. So you're going to have to put that caveat at least on that, on where we're at right now. So I think, I know in Des Moines, we work very hard in this area. So communication from a hospital perspective is key. So between us, Unity Point, Mercy, Clive Behavioral Health out in the western suburbs, if we get overloaded, we're communicating with our hospital partners about, you know, that fact. And so to me, it shouldn't be one family or one child, or if they're in need of a bed and they're with a crisis person, or they're in an emergency room. We've got a good provider network to, I think, collaborate and try to resolve those situations.
Yeah, and you mentioned workforce, Steve. I think everybody on this call, certainly the three of you, can agree. I think you know, workforce is not just a challenge when it comes to human and social services. It's probably across every industry, and not just in Iowa, right? I'm curious, when you do talk about workforce, how do those challenges apply specifically? You mentioned sort of the, you know, the unavailability of beds that otherwise might be available. Is that specific to, you know, certain roles when we think about mental health or crisis response? What is the workforce challenge there?
Yeah, it's interesting because I think we've, you know, there's definitely workforce issues in the medical side of things. We have not closed any psych beds. We've got 44 adult psychiatric beds here. We've rearranged things at times due to COVID concerns, but we have not shut down any beds. Others, I know Clive Behavioral is set to be a 96 bed facility, and they launched right during, you know, COVID. And so that has hampered them, I know, from getting the capacity to where they want to be. So, but it's been funny. We, at the same time, a year ago, we launched an expansion of our mobile crisis services for Polk County, which is a collaborative model with Des Moines Police and other police and first responders in the area. And then also a 911 diversion program patterned after Austin, Texas. And we've got that. We're almost fully staffed for 24/7 mobile crisis coverage. So, and if you would ask me a year ago if we would have gotten there or not, I would have been. So, and I think the crisis services, and I think Marissa's and our staff have been key on this. And I think there's a number of stakeholders and Health and Human Services that really gave us a broad set of disciplines that we can plug into that mobile crisis. So it doesn't have to be a master's level, or it doesn't necessarily have to be a nurse. So, you know, Marissa's been on point with really having the right criteria we need to plug in there, because in some cases, it can be, bachelor's level with crisis experience. And as long as you're really operating within a team model and you've got the right professionals for the right type of situation. So anyway, I think, so Brian, to the workforce issue, and I know we're in Des Moines, and I know a lot of people aren't in Des Moines, and so have the luxury of a larger population, but the main workforce issues right now are really nursing. So it's RNs, it's patient care techs on our units that have the direct interface with a lot of our patients, therapists. And so we've, the legislature worked on some resources available more at the rural statewide level. We've been working with Polk County to do some workforce options, resource options here locally, and we're excited about that. And I think it's really caused everybody to pull together. And we have a coalition going between all of our area hospitals and all of our nursing schools to come together. We've been meeting regularly and developed an official consortium. So it's pushed us all to really put all of our heads together and I think we'll come out stronger at the end.
Yeah, I think that collaboration is really interesting to hear. Mark, I want to bring you into the conversation here because I think you have a unique perspective on that also. Coming at it from maybe a different place. What are your thoughts around the workforce side of things and some of the, maybe both, right? The challenges that exist certainly, but what opportunities do you see looking forward about what should or needs to happen there? Oh, we'll get you unmuted here.
Perfect, thanks. I was like, I can't unmute myself. And I was having a coughing fit. No, I think that's true. And a little bit what Steve was talking about to jump on that with workforce is that, there are a lot of things that we want to do, more services we want to do, better services we would do with more people, and we're looking for them. We maybe even have funding for them. But finding qualified people to do the work has been a challenge for us. And so like an exact example of that is that one thing we do in our area, and again, I'm from the Iowa City area, is that we always have like a winter overflow shelter. Many communities do that too. Last year we had to start way later than we wanted to, way too late into the system because we didn't have staff to be able to staff it, qualified staff to staff it. And we're in the same boat now that we've been trying for months to catch up on hiring with just the current programs that we offer. And to try to catch up and fill positions. And so that's been a challenge. And I worry that there are people going to suffer from that, from some of these, life and death interventions that different providers are able to do to folks because of the workforce shortage and being able to struggle. We certainly, looked at all of these different things, including increased wages. And unfortunately, we don't have an industry or a product that we can raise the price of or something like that to do things. And so when our funding streams are our funding streams, we're kind of tight. I know that wages aren't everything, but on the flip side of it, as Steve was saying, it has made us look a little bit differently about how we hire, who we're targeting. And one thing that has really been a good thing, and I see us coming out in the end, is working with folks and hiring more folks who have lived experience in the field and maybe don't have work experience and maybe don't have the educational background and training that traditionally we've looked for in some of the positions that we have, but folks who have a lived experience and are looking to get into the field to help maybe along the way that they had received help along the way. And it's a different population of employees that we're trying to target now to work with us. And I think that's going to be in the long run, a really effective way and a really a positive benefit to what we're doing. So again, it's causing us to change a little bit the workforce challenges and just being able to find folks being able to do the job. I'm looking at different folks, different perspectives to have people, and I think again we're going to come out good in the long run, but in the short term, it's a challenge, and I fear that there is going to be some services and things, and I fear some of the worst at times if we're not able to do all the services we're able to do because of workforce issues.
Right. Yeah, the challenge is certainly very real, right? When I think about, in recent years, I know there's been some conversation and dialogue at the state level around educational licensing requirements, those sorts of things. And certainly there's value there, like you all talked about, in terms of, different services and the expertise needed to provide those services. Marissa, from the state perspective, with that understanding of some of the staffing issues and workforce challenges, what are your thoughts in terms of the opportunities there around, looking at some of those things, and how do we bring in some of those other people that Mark sort of talked about that can help deliver some of those very vital services that are needed?
Absolutely. This is actually one of my favorite things to talk about right now, which is going to sound so nerdy. So my apologies in advance. But, so we're in the process of doing a really significant alignment of work here between public health and human services work here in Iowa. And one of the biggest and first gains that we get is administrative simplification. And what that means in real life is this. I have services in the division that used to be here just with DHS legacy pieces. And we do accreditation on those services. And I have made decisions, as Steve mentioned, for the past couple of years to give a lot of exceptions to policy in those accreditation spaces when providers can show us that they have staff that are in place that are ready to go, but maybe have a different set of education, background, experience, whatever the case might be, than what is currently embedded in our rules. So we've been tracking on that work that we do and really considering what is it that we actually need in these spaces. And we're kind of getting ready to start really thinking about how we put that together with some of the licensure pieces that have traditionally been held over in our public health side. And that's going to help us in this pathways toward starting to put the pieces together so that it's simpler for our providers, frankly, to understand where they're at in a process, and they don't have to go through like 13 different steps with 3 different entities in order to arrive. But it also is going to essentially mean that we have a better investment of our dollars, which means more money to the services for Iowans at the end of the day. That's the reason I get excited about it. Like I said, it's this remarkably bureaucratic, dorky sounding thing. But at the end of the day, when we do it better, that means the money that we're investing right now through our tax dollars is more directly going to services for Iowans. And that's ultimately the goal. We have all kinds of spaces that we're going to be able to do that. Just when I think about the work that's in my line of sight under behavioral health, we start to think about how all of the things run and how all of them connect together. The places that we've done work 3 times in order to understand our provider networks, for instance, kind of thinking of some things that Steve was saying earlier. And how do we better hold that information in spaces so that it's more readily accessible for folks in a way that is kind of unified, right? One source of truth. Everybody doesn't have to go out and reinvent a wheel. So we're thinking a lot about those things because our story here is that we've made significant investments in this state in order to do right by people when it comes to our behavioral health needs. What I think we haven't done is made significant investments that were also embedded in a system that was built to work. We've been very siloed, very individualized about it, had a lot of different interpretations of how things work. So we're gonna start a process of really truly lining that up. What we need as we kind of get that work rolling forward and what we'll be seeking for is we're going to continue to need a lot of feedback, right? What I don't want to do, what I worry about, because most of my experience is provider side, I worry about breaking it. I don't want to move something over here because it seems like a good idea and I like to mess around with words or something of the sort and then end up breaking it so that it doesn't work on the outside. It doesn't work in the provider space. It doesn't work for the work that we need to do. It slows the process down, whatever it might be. So that's going to take us a while. It doesn't happen overnight. I'd like to flip switches, but I don't get to do that. It doesn't work well. But it's exciting stuff to think about because, like I said, at the end of the day, getting those resources back into our providers where they have the money to be able to get the people that they need, get them on the floor at a hospital, get them into the facilities that they need to be able to provide those services and catch folks in crisis. Ultimately, at the end of the day, that's the goal. We don't want to spend that money on administrative expenses anyways. That's no fun. We want to do the work.
And I think just to add on to that, Brian, I think the license, we know our licensed professional staff, whether you're talking about physician level, therapy level, nursing level, what have you, that license represents a symbol of public trust. And that's why Health and Human Services and Iowa Department of Public Health and licensing bodies does all that work, is because we want the public as they enter our services to have a sense of, okay, well, this person's got a license. At least I've got a minimum level of trust that they're competent to do the work they can say they do. So, I mean, I think we sort of all breeze by that because we're just sort of, we're in the midst of trying to get help, or maybe I'm a family member, but that, to me, that's very important. And so I think, but I appreciate Marissa and her staff looking at everything to see how we can reduce the administrative burden. But I think we just have to make sure we're knowledgeable about that's a very important topic, because we've certainly had examples in the state over my career where we had care that wasn't involved with a license, and things may have not always gone as well as we would have hoped. So anyway.
Yeah, that makes sense. Wouldn't it be much easier if we could just flip the switch sometimes? We need the magical switch. But we got a couple of questions that came in from the audience here that I want to throw at the group. And for those listening, continue to feel free. We've got a couple here that I think are really fantastic. But feel free to continue submitting those questions through the chat, and we'll introduce those to the panel here. You all were talking about, the workforce issues that sort of everyone is really facing. And someone from the audience had mentioned it really doesn't kind of help with the rates, reimbursement rates that don't allow for better staff pay, a better wage. And how that kind of trickles down to just frankly not making it possible to have enough staff, to have enough of a workforce to provide the necessary services. So how does the state look at increasing reimbursement rates for those that are in crisis services?
Sure. That's it's been a couple of years, but I'll put my Medicaid hat back on for a second. And so in general, the way that we look at how we're looking at rates in the state of Iowa has been relatively piecemeal. Meaning that we get feedback from our provider community that tells us that the rates aren't a match anymore to the work that they're doing. And we get appropriations from the legislature. And oftentimes the appropriations, of course, are based on the feedback that they're hearing from the community and from their constituents. We're in a process now, and here at Iowa's our Department of Health and Human Services work again, of really bringing rates and reimbursement a bit more forefront, to be more proactive in reviewing those rates and really making sure that we're keeping up with changing times. It's a big build to get from here to there. It isn't work that we've done before, but we've started to see some successes from that just here recently. There's been some significant work happening that folks haven't probably had a chance to see yet, unless you've been engaged in it, but significant work happening around establishing a tiered rate for inpatient psychiatric care, for instance. The absolute aim of establishing a tiered rate is to allow our hospitals to staff appropriately for high need individuals, because that costs more money. When you are serving people with really significant needs, you need more humans a lot of times to be able to do the work. And hospitals often say no to people that need inpatient care, not because they don't want to do it, right? This is the reason to exist. They're saying no because they can't. So that's work that's been happening actively. The Medicaid team's been involved. We've had our hospital association, Steve's been on there. We've had a bunch of folks at that table working on that rate development. And I think we're going to see more examples like that going forward. The other things that we think about from here is there are things that are outside of rates that also are important in how we make sure that we have a workforce. We have to make sure that folks are competent, of course, and we have to make sure that they're confident in what they do. And there are spaces that we believe that we should be playing here when we think about that from a health and human services perspective, and making sure that training is adequate in order to achieve that. There's potential in developing training in some spaces so that providers individually don't have to chase it themselves. The idea that, those things can have a home. Again, now it's administrative simplification again, right? That's what you're talking about when you think about those things. But, you put all your resources together, and what you can get is something that's big and comprehensive rather than, chasing it individually at our own levels. We also think about things like the simplification of billing processes so that less money is going into your administrative bucket as a provider yourself, right? Because all of those things help. Your rate isn't just paying your provider of services directly. It also has to cover all of your administrative expense tied into the operational work. The less that we have to do operational work that's wasting our time, the more of our rate is able to pay our providers who are really providing the care. So we're trying to be thoughtful about all of those points that touch, and really thinking about how we can, best use those dollars that we've invested to do right by people.
I would just add on to that, I think, Brian, in terms of, and yes, the legislature did step forward with the tiered rate or psychiatric intensive care. So I think for the audience, if you weren't involved in that, think of like a psych ICU, and it will help us with citizens with very high needs to serve them much the same way we did with many other hospitals did during COVID, where people from rural areas were helicoptered up to our facility because the rural areas didn't have an ICU and some of the oxygen resources. So that I think that particular effort by the legislature and by Medicaid, Health and Human Services is a big step and an influx of dollars into the mental health system. So I appreciate that. And then I just think all of us, like Marissa's saying with HHS, is all of us need to look at the patterns we've developed and try to figure out where there's duplication, where there's areas, because every dollar counts. And so if we can do things smarter and not do them 2 or 3 times, that's going to have to be, because everything's going up. We've got oncology costs or drug costs are up 20%. It's costs are going up everywhere. And so all of our CEOs and CFOs are, losing sleep over trying to, balance a budget. So I get it. I totally get it.
Yeah, I want to sort of expand on a couple of things there, because I think that's really interesting. When we think about, Marissa talked about, and actually we had a couple of questions around this too, but it's sort of a big topic here. You mentioned earlier getting people into the hospital or other service where they need it. We know that we have access centers that have come online. Mark, I think you have a really unique perspective on this on that side of the world. How do we ultimately, Steve, I think you have talked before about sort of the default being hospitalization, that, for a number of years, hospitalization was really the default when someone was in crisis. Knowing the challenges that presents, and knowing that that's not always necessarily the right answer based on all of these other available resources out there. Mark, maybe let's start with you on this, and then I'm curious about everybody's perspective though. How do we make sure that people are getting in where they need it and sort of meeting them where they're at?
Yeah, gosh, I'll try not to talk forever about this. This is my world. But the reality of it is that, when we talk about crisis and we talk about mental health and all of the different, you talked about, crisis stabilization beds and these shorter term ones and these subacute beds and all of these types of things that are great perspectives. The reality of it is that many of them, they're all voluntary. And what we find is that shelters have really become de facto crisis beds, and they're not looked at as that. And, when we have, and I'll get into this a little bit more, but, psychiatry comes on site to our shelter and our different housing services that we have. And, they've walked around and made comments that, wow, you are the meth detox. You are an inpatient psych that is not staffed as that. And when we've had these conversations before with, we were talking about Medicaid, Marissa was talking about Medicaid and reimbursements. And when you bring up the world of homelessness and that, typically in healthcare and Medicaid specifically, it has been looked at as it's a housing issue, it's a homeless issue, it's a homeless issue. It's not any of the other types of issues. It's not a mental health issue. It's a substance use, it's whatever. And so we've been kind of in a nice way laughed out of the room at times in some of these conversations that we've had. No matter how much data and things we can talk about, that's what shelters have become over the years. And so I can tell you that the work that I've done is we can have all of the crisis services available, but without having things and looking at the other side of it of having safe, affordable, permanent housing. None of it really is going to matter to certain populations. And it's been a challenge for that, that I think about how many times that folks go inpatient and had a severe crisis and a suicide attempt or homicidal thoughts, and they went inpatient at the hospital, and the discharge is where? they don't have anywhere to discharge to. And so they're calling us. We were then work with them. Well, all the work that they just did 3 weeks inpatient, and that sometimes can get lost pretty quickly when all of a sudden they're back in crisis of, where am I going to stay tonight? How am I going to eat? Where are my belongings going to get stolen? Do I have this? Do I have that? All of the things that come with being housing insecure. One thing that we have found, maybe back to your original question, Brian, I told you I wasn't going to ramble, and I sort of rambled, maybe got passionate about it, but what we've figured out, one of the challenges with any type of healthcare is, availability, accessibility of it. You have to go to the environment, you have to go to the hospital, you have to go to the clinic, you have to go to wherever. And so we worked for years with, we have the University of Iowa hospitals and clinics in our community, which is a real benefit of having, how do we get psychiatry on site? Our agency, we don't have the ability to afford a psychiatrist, not even a 10th of a position, not even a whatever. We don't have that ability. And so psychiatry department at the University of Iowa figured out a way that they can have a residency, that someone does a community psych residency. And what they do is regularly come to people. They come on site, they come to the shelters, they come to our housing provider or housing services we have. They come to our parking lot. Those types of things, these mobile crisis things, they're mobile healthcare units, not mobile crisis necessarily, but mobile units. And they're meeting with folks. And instead of going, hey, you know what? You can get an appointment in 6 weeks. Person that's on the streets, person in a shelter, person that's bouncing around from couch surfing. It's nearly impossible for them to keep their appointment. And so, all right, the appointment is today, right now. I'm coming to where you're at, and we're going to have an outpatient psychiatry appointment. And it's worked wonders for people. It's been great. And so those are the types of things that how to bring services to people. It's really been life-changing for people, and it's really small scale because it's something that just our community is really focused on. And we've had some real champions in psychiatry looking at how to ways they can improve things. But I think as we continue to be nimble and creative in ways that we can bring healthcare and psychiatry, especially to where people are at, as opposed to having to go to the clinic, having to go to the hospital, having to do that, we're going to continue to see these tremendous results. The last comment I'll make on that, we also have apartment complexes that we own. We decided that we need to, and we provide services there. Sometimes intensive, sometimes very little, but they're available to folks. And psychiatry is on site there too. They're on site there at least 1 day a week. And they're working with folks, and for folks that have been really hard to and very challenging, some of the most challenging folks, they're engaging with those services. They've been housed for years, months and years at times where they haven't been before. And so again, just being creative about how we're delivering services to folks, along with being creative on housing types that people have, because all of those combined are what's going to make, in many cases, the system work better for folks. Period. I'll stop talking. The rest of you.
I think those are great points, Mark. And I think having psychiatry on site, to me is just phenomenal. I've been part of a provider system that has matured over the years that, is really built more on providers than client access. So I think that's a great example. And I think, you mentioned access centers, and certainly that's been a major state movement. We started a psychiatric urgent care. We just decided to vary from that name, access center, but we started that about 4 years ago. So they do have to come to the hospital, but it's all walk-in, and we can do medications, therapy. But I think, and I know there was a bill, and I'm sure Marissa knows this better than I do, but we are expanding those residencies through the University of Iowa this next year. And I know Jody Tate very well from the University of Iowa. She was just over here for a tour a couple of weeks ago, and she's heading that up. And I think I'm betting there's going to be more examples like that, potentially, maybe even in other parts of the state. So because that residency does allow you to so many chances to get a little more flexible with some of your resources. So that sounds like a great model, man.
I'm excited for Jody to head that up too, Steve. one of the things that I think that we have a really big opportunity to look at here, thinking about all of those pieces that you're thinking about every day, Mark, is when we think about what we can and can't pay for through different funding sources. We haven't planned that well in our state previously, in part because we haven't had a well-connected system. There are things that you can and can't pay for in a Medicaid bucket, and the pathways to get there are often blocked by federal authority, right? You can want things, but if the federal authority tells you no, it's going to be real hard to get there. The fortunate thing for us is that we have that significant investment now from the state of Iowa when we think about how we're funding our regions and how we start to plan our system. And what we really have an opportunity to do is target that state investment into those spaces that Medicaid can't go. So you think really, really clearly about populations that Medicaid cannot serve, populations of ineligible individuals, and services and supports and the things that we need in our communities to make them whole, so that ultimately our communities themselves are prepared to meet people. And so that's work that we've started doing together with our regions here in Iowa. We're really excited to keep it rolling forward. We're in this kind of season of a significant amount of change. And our reality is that the way that we've done work through our regions hasn't changed significantly when we think about the funding pattern and our old county property tax levy and how we structured governance and authority, and everything about our regions is still based on the model that it was when it was a county system, and it was intended to essentially support county homes. So this is a really exciting opportunity for all of us. It comes once in a lifetime. In reality, you don't really probably get these more than once. And we want to do it right. And part of it really is digging in on those spaces and getting to those better understandings of what's on the menu and why did we put it there, and being really targeted about those investments.
Yeah, that's the funding conversation I think is interesting when we think about sort of the multiple facets of that, right? Where the services themselves, the human capital that it takes to provide those services, the infrastructure behind that, and what does that need to look like? I am curious, Marissa, at the state level, we talked about the access centers coming online, and I know we're up to a handful, at least that are online now, with the 988 rollout, for example, happening in July. What does that landscape look like at this point in terms of just the shifts that are happening behind, infrastructure, funding? We have those programs, the access centers, 988. How has that shifted, and where does it need to go looking forward?
Yeah, 988 is probably the most exciting development that we've seen come into play in recent years. The purpose of 988 from the national level is it gives people a one number they call 988, and it links you directly to someone to talk to, someone to respond, and some place to go. That's kind of the language that's been used around 988. What it means is that it's the National Suicide Prevention Lifeline, but it has really pivoted into being a behavioral health crisis line, accessible to everybody 24 hours a day, 7 days a week, and linked in to our local providers of crisis services. We were fortunate here in Iowa that we had two providers who were already our call centers and our text centers for the National Suicide Prevention Lifeline, and that's Foundation 2 and Community over in the Iowa City area. And they're both on board with us for 988 as well. Our rollout has been incredibly successful. A year ago, we were responding to a little less than 70% of National Suicide Prevention Lifeline calls in state here in Iowa, which meant that about 30% of the time when someone called the Prevention Lifeline, their call rolled to an out-of-state center. Last month, August, I think it's August. I had to kind of roll back in my head about the last ones that I'd seen. I think it's August. We exceeded 95% in-state answer rate. We answered 99% of texts here in Iowa. That's incredible. And the reason for that is because we've made choices alongside a really robust planning committee for 988 work and alongside our providers who are doing the work to really make sure that we're standing this up to be successful. We were able to get some grants from the federal side in order to do so. So we got our things together. We prepared our work. We put forward for those grants, and we were granted those dollars. And so we have about a 2-year implementation timeline right now of really getting from the starting line of, which is answer the calls and the texts and that sort of thing, to really getting to, by the end of this 2-year implementation, we hope to have a really clear idea of what the infrastructure need will be, for instance. So what does the call center itself what's the IT infrastructure going to have to look like? And how are we going to, as quickly as possible, as smoothly as possible, make those connections into a local 911 dispatch, if that's the direction that we have to go, or to those local crisis services? Does it look like centralized dispatch, or do we still do dispatch from a more local level? All of those things are going to have to still be figured out and sorted out along the way. Right now, our mechanism is warm handoffs, which means that if we're connecting someone who calls into 988 to a localized service, the 988 is number, their call there is making that warm handoff or connection into their localized services. So we've got work left to do, and that's really infrastructure work. But given the start was really just, okay, everybody, here we go. We put a lot of planning in, but you don't know how it's going to be till you go live. We could not be more excited about how that looks. We think future tense, it's a significant lever in the system. Giving people a resource that's easy to remember, and giving them resources right away when they call, crisis counseling, connection to those services in person, whatever it may be. That is the sort of thing that does save lives. That's the work. It gets people both what they need right now and in real time, as well as follow up after the fact to make sure that they are okay, to make sure that they are connected to the services that they needed. That's life-saving work. That's work that we're all going to do together, because it doesn't happen through just one place. It happens through building a network and really making sure that system is built to be a functional space. So we're really excited, really proud of folks, and really excited about that 988 work.
Yeah, as you should be. The growth on that in a pretty short amount of time is pretty impressive to see, and certainly exciting. I think, Steve, you talked about obviously, like I mentioned before, sort of a default toward hospitalization, which happens when somebody actively walks in, right? Mark mentioned it's sort of that group where I know I need the services and I'm willing to walk into the hospital. Mark, you're sort of on the opposite side of that, where it might be a lot of population that needs that help, but maybe is not necessarily willing to walk in. They find themselves in other circumstances. Steve, let's start with you on that. I'm curious, when you think about the rollout of 988, the infrastructure developments and all of that happening, what role, or how does that shift maybe the role of hospitals? What can hospitals do? And how do you sort of address that in the best way possible with the segment of population which is a large segment of the population that has really relied on hospitals as kind of the default?
Yeah, I think there's a number of things that go into hospitalization. Sometimes it can be, family, friends, sometimes law enforcement, sometimes there's a civil court order where the sheriff or deputies are bringing them in. So they can come in a number of different ways, but I think 988 and all these crisis services are really intended to move upstream hopefully before all that happens. Are we going to hit everyone 100%? No, but I think this will improve the need for hospitalization. So I think to me, these are all great efforts to try to, move the needle on. Yep. 20, 30 years ago, we were telling everybody to go to the emergency room if they didn't feel safe. Now we're saying, okay, call 998, be able to hopefully intervene earlier. And then if you need to see somebody today, yep, we can make that happen. And I think you're going to see more and more of that with the access centers and urgent care and so forth. So to me, it's really, we're just sort of turning the Titanic here, and so have some patience, but give us feedback. But I think it can be a great, this is a great page to turn here. So.
Yeah, absolutely. Mark, what about from your perspective with, I know, community in the Iowa City area, I think GuideLink in the Iowa City area. How do you fit in there in terms of really a pretty large segment of the population that you're working with that may need connected in some way, shape, or form, and may not be sort of the more traditional route when we think about that default to hospitalization?
Yeah, the one thing that 988 and these behavioral health access centers that have come along, they're great for all the reasons that we talked about, because we're trying to get creative as a state of different ways that we can that people can access, as opposed to going to the ER, going to and going to inpatient. And they can access, behavioral health services. And so all of those types of things are great. What we find is that there are times where, again, like everything, they're not the answer to everything. And that's one of the challenges. And I sort of talked about that a little bit. What we find a lot is, people are maybe violent, maybe threatening, and that aren't able to access some of those services. 988 probably not, but more so like the other types of behavioral health services that we're doing. And so again, there isn't a lot of options for some of those folks that we talked about. And I think that's maybe a gap we're missing too. There's been a little bit of a theme, and especially from Steve talking about it, I think, of how do we keep people out of the hospital that don't necessarily need that type of service. And I know that I always change it to housing type stuff, but it's such an important piece of this, because over the years in our community, we were working with hospitals, emergency rooms, inpatient psych, police, jail, all of these different providers of. There are people in our community that are continually cycling through and accessing all of these services all the time, with the end result of this circle of they end up back on the streets, they end up back in jail again, they end up in prison, they end up in the emergency room, they end up in and nothing ever comes out. And so what we've started looking at of like, how do we keep them out of hospital? How do we keep them out of jail? And to get community buy-in, we really jumped on things such as it'd be a lot cheaper to just provide a housing subsidy to them in some way, as opposed to having them go through that. And so people got interested, and we talked about cost savings. Now, of course, I'm certainly interested in that, but as a provider, I'm also looking at the human end of like, I don't want to see them back on the streets again. I want to see them back into housing. And so we really worked hard of it's expensive intervention of permanent supportive housing, but providing housing for these folks with subsidies, with supports, the correct supports along the way. And we've been working very hard to kind of show a 3-year study now of what's quantifiable savings it's saved to the community for a number of folks, and then the qualitative side of it too, of like the life-changing things for some of these folks that have happened, and having a research study with somebody to do that, so that we can show that the importance of housing and supports for folks does for the system, especially for folks that maybe don't traditionally accessing the behavioral health system, and how those types of things can help save money to communities and states, but also has really good responses too. So I think that's the end I see too. We continue to be creative on ways to do things, and 988 and behavioral health access centers are just examples of that. Of like, let's continue to creative, and let's find ways to help new groups of people that are not going through the emergency room or going to the hospital. So.
And I think Mark's exactly. I mean, my whole career was. Affordable housing, I know in Des Moines, I'm sure Iowa City, I would venture to say Des Moines and Iowa City are probably the most challenging in Iowa. So I know that's a hard fact to deal with for a lot of our case managers, integrated health homes out in the field, because it is a challenge. And if you can find the subsidized housing where you can go by, Section 8 guidelines, then we have a large YMCA complex here in Des Moines, just south of downtown, that has a very large number of units that are single room occupancy that can't access Section 8 guidelines. And that's been a huge resource here in this area, I know, and they have case management on site, and other case managers can come in. So it's a huge part of it. It definitely is, the housing piece.
Marissa talked earlier about we're in sort of once in a lifetime opportunities right now, and we all can talk about the challenges the pandemic brought. What it has given us in different ways is resources that we may never see again for some of the types of stuff we're looking at, whether it's infrastructure for this type of work, in my world of housing, there are some pilots that even the state of Iowa is doing right now that are wonderful, that helped to do that, of rapid rehousing pilot, understanding the importance of stable housing and how it addresses behavioral health issues. And there are providers all across the country that we have, or all across the state, that that we have, rental assistance available for people and the way they can access it. And that's a little bit controversial at times because people don't, sometimes they think of it as a handout and it's people not working hard for things, but the reality of it is we're keeping people out of crisis. And if we're paying arrears for people, or if we're paying the rent for them while they are dealing with their behavioral health crisis, or even just a crisis in general of life, of people that experience when they're living in poverty every day, that it helps all of the system that we're talking about too. And so all of these investments, and there's these pilot projects, and even Department of Corrections has been talking about, investing more money in discharge planning for folks, of housing assistance at times, to maybe help recidivism in the prison system. But I think it affects all of this type too. It also keeps them out of the behavioral health system too at times too, because the housing piece. So there have been some really looking at some of these things and this life-changing opportunities we have right now that we may never in our lifetime probably won't see these opportunities again. And it's a really important thing. And Marissa, you have a really important job too of figuring out all of these types of things too. What's the best way to invest this type of stuff? Because we probably won't see it again in our lifetime. So it can change the state of how we're at.
Fortunately, we got a really big team. I mean, not even just here, when we think about the team here at HHS, but just the team of folks that are, folks coming along with us and supporting us and giving us feedback, Mark. One of the things that we get to do in the realignment is it takes, you're taking a fresh look at all the work that you do. And one of the really cool pieces that we're kind of discovering as we go is, just like everything else, the work that we've done around housing and homelessness has been siloed. And so putting together the transitions in homelessness, the PATH grant work with the rapid rehousing work, with permanent supported housing work that is an evidence-based practice that's implemented within some of our regional spaces right now. Putting all of those pieces together and giving us some subject matter expertise from here to help guide a system forward, rather than kind of a scattershot approach to, a single intervention sort of thing. It feels hopeful. Now pulling all that off and figuring out how it all sorts, like kind of Steve said, that's a bit like, kind of steering the Titanic a little bit, or not the Titanic, gracious sakes, but steering the battleship a little bit maybe. But the exciting thing is that there are a lot of resources. They've been scattered, and we're taking that fresh approach to looking at it to try to make those pieces go together, because you're exactly right. Housing is such a significant piece, but really a lot of those spaces that we think about when we think about social determinants of health, and how do we really invest those dollars upstream, and how do we catch people sooner? And so that folks that need hospitals, they need the hospitalization, they need stabilization, they need care. But when we can get folks a house, a home, a permanent space, and having that permanency is the thing that is going to stabilize their needs long term, why in the world would we invest money into a whole bunch of ancillary services, essentially, when the thing that they need is a safe place to rest their head? That's a reasonable approach to take. We just have to figure out how we're going to make all of those things work so that it fires on all cylinders and gets people the right care that they need at the right time.
Yeah, Marissa, this is a perfect transition with what you mentioned. And we have just a couple of minutes left here. I want to ask this question from the audience, because I think it plays right into what you had just talked about. And then I just have one final question for the group. Someone from the audience had asked, are we considering at the state level combining mental health and substance use disorder funds in order to make it easier, right? When you talked about sort of the evolution from the siloed approach to how do we look at that? Is that a consideration at the state level?
Yeah, it is. So the work that we've done when we think about the Health and Human Services alignment very specifically brought together the Bureau of Work that is our substance use disorder work, and the Bureau of Work that has traditionally been our mental health and disability services work. And I serve as now the state director for all three lines. And so the answer is, yeah, we are thinking actively about how we look across that now an entire much larger division of work, and really combine those efforts while maintaining areas of specialty. Because the reality is that care delivery still has to be specialized to people's needs. But the other side of that reality is that co-occurring diagnosis in the behavioral health space is the expectation, not the exception. So we really have to build a system that supports that care to happen. The idea that someone with co-occurring diagnosis, for instance, who really very much needs to access substance use disorder treatment, but is struggling to get it paid for because it's not their primary diagnosis, we have to address that. that has to get better. Because our reality is that for a lot of folks, they can't get well if we only treat one side of the effort. We really have to make sure that we're investing some of those resources into spaces that develops cross competency and training as well. We think about the spaces that have built up in our mental health world. Steve mentioned integrated health homes a while ago, very much built up in our mental health spaces over the course of time. It left a lot of our integrated health homes without a great connection back to how they best care for or understand patients who are also presenting substance use disordered needs. And that's a space that they need understanding and knowledge about in order to do their work the best. And they know it, right? They ask for it sometimes, but they've been siloed off by funding streams for a really, really long time. So we need to kind of be thoughtful about the process. I do think we're contemplating things like putting forward a combined block grant application. So our substance abuse block grant and our mental health block grant. Most states often put together a behavioral health block grant application. You still have all of your services. You still have all of your expectations that are associated to those services, but you're aligned to similar goals as you're progressing a system forward. So we're absolutely thinking about all of those things. We think that that's exciting work to do. And we can't think about it by ourselves, frankly. I mean, that's another of those pieces that at the end of the day, we've got a big process to make our way through here and really understanding, if we move this thing here, when we think about the block grant applications, what are the downstream impacts? What are the pieces that we need to put together to make sure that all of our providers are able to understand the change, make sure that people are ready for the change, make sure ultimately that Iowans get the services they need.
Yeah. No, that's perfect. And that actually really kind of addresses the last part that I wanted to touch on. So I appreciate that. I know we're just a minute over time here, so I apologize to cut off such an important conversation. I think from everything you all have talked about, right? Just the innate crisis response needs, the human capital, the infrastructure, housing, all of that combined. There's a lot of moving pieces to that. And I think you all bring such a unique expertise, the work that you're all doing in that field and that space to serve Iowans. And so I appreciate that. I think we all do. Thank you for sharing that with us today. Thank you everybody in the audience for hanging on. After this, we'll be at lunch. Following lunch at 1:15, everybody's invited to a featured speaker series with Director Debbie Durham and Director Beth Townsend, both from the state. And then we'll dive right back into more sessions around the human and social services. Steve, Mark, Marissa, thank you so much for joining us today. Inclusive ICR, ITC Midwest, thank you from our sponsors, and hope to see everybody again here shortly.